Hi, I'm Dr. Fred Pordat of the Texas Liver Institute. Welcome to the Texas Liver Institute Lecture Series. Today's discussion is hepatic encephalopathy, or HE. To preface our talk about hepatic encephalopathy, we'll start by discussing cirrhosis of the liver. In this graphic, you see a normal liver on the left and a cirrhotic liver on the right. The cirrhotic liver is very scarred, very small, and has difficulty. The liver has a tremendous amount of blood flow through it every minute. There are blood vessels that come into the liver, blood vessels that leave the liver. If the liver is scarred, then impairment of flow leads to what's called portal hypertension. You have increased resistance, high pressures, and difficulty for the blood to actually get through the liver. This portal hypertension then leads to several consequences, one of them being hepatic encephalopathy. We discussed the other ones, such as varices, ascites, and a large spleen, in another lecture called cirrhosis. Hepatic encephalopathy, then, is the topic of today's discussion. What is it? It's an impairment in cognition, or the ability to think, memory loss, change in mood. All of this is caused by toxins that the liver can no longer clear. There are two types of hepatic encephalopathy, what we call overt, or obvious, and covert, or minimal. It's easy to make the diagnosis of overt hepatic encephalopathy, and over 50% of patients with cirrhosis will ultimately exhibit this. It's a much more difficult thing to diagnose minimal or covert hepatic encephalopathy, and other types of testing needs to be done. One of the classic features of overt hepatic encephalopathy is a flapping tremor called asterixis. But even if this is not present, a patient may have hepatic encephalopathy. We must always look for precipitating causes such as gastrointestinal bleeding, infection, dehydration, or medications. Many times none of these can be found. But once we make the diagnosis of hepatic encephalopathy, then we have to treat it. There are a few treatment options, but very few that are actually FDA approved and safe for the patient. The most commonly prescribed historically has been a drug called Lactulose, and I'll talk more about this, but this is a non-absorbed disaccharide sugar. Non-absorbed antibiotics are also another way to treat hepatic encephalopathy, and the best known of these is Rifaximin. An older antibiotic called neomycin is rarely used because of its potential to cause injury to the kidney. Other drugs such as Flagyl or metronidazole and vancomycin are almost never used anymore because of their long-term side effects. So lactulose is a non-absorbed sugar. How does this work? Well, it actually changes the pH and makes the bowel more acidic. This then traps ammonia, which is one of the things that causes hepatic encephalopathy, and allows it to be excreted. So what's the problem with lactulose? It seems to work. However, it causes many side effects such as abdominal bloating, gas, flatulence, nausea, diarrhea, and can lead to severe dehydration. Most patients don't like the taste of it, and therefore adherence and compliance with this compound is actually quite poor. What about rifaximin? This is the best known non-absorbed antibiotic to treat hepatic encephalopathy. It actually works by a different mechanism. It affects the bacteria that produce the ammonia, decreases the ammonia concentration that way, and decreases some of the other bacterial byproducts, and that seems to get rid of much of the hepatic encephalopathy. None of these drugs by themselves are perfect, of course, and patients, even when being treated, will still have episodes of hepatic encephalopathy. In a phase 3 registration trial, rifaximin decreased the likelihood of having a breakthrough episode of hepatic encephalopathy by almost 60% over a 6-month period. Just as importantly, it decreased hospitalizations by 50% over that same 6-month period. This is very important, as keeping the patient out of the hospital decreases the chance of acquiring a new infection in the hospital and improves quality of life for the patient. So, hepatic encephalopathy caused by cirrhosis, portal hypertension, really changes a patient's quality of life by affecting their ability to think, their memory, their mood. So the first step is we must recognize it. It can often be very subtle. Sometimes sleep disturbance is the very first sign that someone has hepatic encephalopathy. The next step is to treat it, and treat it early. Don't wait until the patient enters the hospital. We need to detect it as an outpatient, put them on therapy, and hopefully improve their quality of life and maybe even prolong their survival. To learn more about hepatic encephalopathy, please visit us at www.txliver.com. Thank you for your attention.